Assalamu alaikum wa rahmatullahi wa barakatuh. I'd like to welcome all of you to this session. Just to remind you once more that you should only have had to sign once a day for your CPD. And we're going to try and get moving. We have 4 excellent presentations this morning, and we're going to try and get through them and leave some time for questions. Just a tarbiyah and a reminder to ourselves. Allah subhanahu wa ta'ala says in the Quran, in Surah Yunus, أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم يا أيها الناس قد جاءتكم موعظة من ربكم وشفاء لما في الصدور وهدى ورحمة للعالمين. O mankind, there hath come to you a direction from your Lord and a healing for the diseases in your hearts, and for those who believe, a guidance and a mercy. We hope, inshallah, that we can get some messages on healing from our various excellent speakers today. Our first speaker is Dr. Nasreen Ghulam Mayuddin. Nasreen is an endocrinologist in private practice at Life the Glenwood and Life Bedford Gardens Hospital. She is an honorary consultant at Chris Hani Baragwanath Academic Hospital and has a keen interest in academic medicine. She was awarded the Carnegie PhD Fellowship in 2015, and she remains actively involved in teaching under and postgraduate students. She is going to talk to us about biomedical evaluation in common endocrinopathies. Nasreen, welcome. Assalamu alaikum wa rahmatullahi wa barakatuh.
Rushing, and I know we're running a bit late. It's so nice to see so many friends and some mentors in the audience. I hope, inshallah, I do this presentation justice. So, just a brief outline of the talk today. I'm going to do a short introduction, and then we're going to cover 3 cases. I'm going to try to do them quickly, partly because I know we're running late and partly because I'm a bit afraid of Shuaib. But just by way of introduction, right, I just want to start off with a little rider that we're going to try and do some short vignettes. Because when you looked at the abstract, I think I may have bitten off a little more than I could chew. There are several topics that we're going to cover. But each of these vignettes is designed to illustrate some practice points. And the focus of them is on the biochemistry. So I'm not going to dwell too much on the clinical aspects, and there is going to be little, if anything, on management strategies, because that's really out of the scope of this presentation. Now, we know that biochemical testing plays an important part in clinical practice, especially for those patients who have subtle signs and symptoms, but even more importantly for those patients whose clinical assessment overlaps to such a degree that it is impossible to make a final diagnosis based on clinical aspects alone. But there are obviously great difficulties with doing this. Part of this is based on the cost of these investigations, part of these is based on the demands of our patients, and part of this is based on the fact that we ourselves may sometimes doubt what is required of us. But having said that, I decided to see where the layperson stands. What do our patients really expect of us? And I did a quick search, and one of the things that comes up high on any search you do these days is the Amazon website. And these were the books that were available for our patients on Amazon. So it tells the patient that they can be their own doctor, which is useful. To be fair, when you look at the little, at a sort of preview of this book, the information is solid. In fact, the preface actually tells you that this is actually aimed at undergraduates for their USMLE exams. But it gives the reader also the impression that by the time you read this book, you will have the equivalent knowledge of an undergraduate preparing for their exam. This one was more interesting. It's a summary of the lies my doctor has told me. And what is even more interesting, it's already in its 2nd edition, but I'm going to tell you a little bit more about it. And the 3rd one, 25 medical tests that your doctor should tell you about. Please go search Amazon. I promise you they're all there, ranging in price from $4 to $50. But this one is not the whole story. The subtitle is even better. And 15 you can do yourself. So our patients are already coming to us with quite a lot of an expectation, right? So this chapter summary is not my summary. I did not do a précis of this book. But what was interesting about it is the summary of chapter 1 says your doctor is probably a good person. Doctors become lazy due to the bills and busy life of being a doctor. But this book is aimed at helping the doctors themselves. The second one is actually a little bit more relevant because it is actually part of our practice, right? And what it starts with saying is that because they fear they will miss a diagnosis and expose themselves to malpractice lawsuits, doctors will start ordering expensive and unnecessary tests in the practice of what is called defensive medicine. Now, this is not necessarily an unfair claim because there are times when we all would say we'd rather do a little more than a little less. But having said that, the rationale for my talk is really going to be based on the idea that we need to apply sound clinical reasoning. And for the 3 case vignettes, I want to go through what would have been my reasoning in these vignettes. Right? So, as I said, it really covers the biochemistry, but I cannot stress enough that the starting point for any diagnostic assessment is the history. Right? And the history is going to give you clues into your examination and then into the subsequent biochemical testing from there. So without further ado, I want to start with case 1. Right, so this is a young woman, 27 years old, and she comes to your rooms or my rooms 3 months after the birth of her second child. And she's complaining of fatigue and hair fall. She also says she's been a bit moody and a bit irritable. And she says she's been using a herbal supplement to lose the weight she gained during her pregnancy. Of course, you try and reassure her that this may not be unusual, given that she's just 3 months postpartum and she has a little baby together with an older child. But you request a few tests nevertheless, including her blood count, iron studies, and a TSH level. Now, for the purposes of this case study, although we often find abnormalities in the blood count and iron studies postpartum, in her case, they were normal. And you come back with a TSH of 0.29. Now, if you look at that reference range, it's just slightly below. And there's not too much we can do without going a little further. So we order the T4, which is normal. There are a few thoughts going through your mind, but given that her symptoms are relatively mild, we watch and wait and look at it 6 weeks later. And we see her TSH is slightly more suppressed. T4 is still normal. There would be a few things going through your mind right now, but her symptoms are the same. She is relatively stable. She's not having any cardiac arrhythmias. She's young, so she can tolerate all of this. We know she's not anemic. And we do yet another test. Oh, sorry, we did the antibodies at that time. And when patients are hyperthyroid, we are worried particularly about Graves' disease, which we know is one of the most common causes of hyperthyroidism. But the most specific test for Graves is the TSH receptor antibody, which is clearly negative. But the others are fairly strongly positive. And now we're stuck. We would think it looks autoimmune, but it's not Graves, and she's still hyperthyroid. So we go 3 months later. Now we're hypothyroid, subclinically, but we're swearing the lab because now we really don't know what's going on. Be that as it may, her symptoms are now improving because her TSH has gone in the other direction. So what do? We repeat. So in a space of 4 months, our patient has had 4 thyroid function tests and has come back to normal. So we breathe a sigh of relief. But can we explain what happened to her? And what are we going to do about those antibodies that are still positive? So let's look again, right? When she was initially subclinically hyperthyroid, she really was very mildly hyperthyroid. So it's difficult to assess. Are her symptoms truly attributable to this mild hyperthyroidism? Or is this a postpartum change? Or are all those symptoms really just related to other factors and not the thyroid function itself? And none of those are unreasonable thoughts. The other thing to consider is lab error, because we know it does happen. And the last thing is, was that herbal supplement she was taking spiked with some thyroid derivative, which has made her subclinically hyperthyroid. All of them are reasonable considerations, and all of them are things we encounter frequently in clinical practice. But then, 6 weeks later, she's still hyperthyroid, and her antibodies are positive, but it doesn't look like this is Graves' disease. Now, what could we do at this point? So, watching and waiting is not unreasonable in a young patient, because we know that a young patient who has no other cardiovascular risk factors can probably tolerate mild subclinical hyperthyroidism. The ideal thing to do in this setting is a thyroid scan. Not an ultrasound, but a radioactive iodine thyroid scan. If it was Graves' disease with the antibodies being negative, you'd pick it up. But more likely, you'd see decreased uptake or no uptake, because this is most likely a thyroiditis. A painless postpartum lymphocytic thyroiditis, which is why her antibodies are elevated. But then she becomes hypothyroid. Is this consistent? Is she now a Hashimoto's? Or is this all part of her original picture? But when she normalizes, we know that this was most likely a thyroiditis. And what I want to show you here is the natural history of a thyroiditis. Before I carry on, I just want to highlight to you the slides that have PDF written in the corner are actually going to be in a pack that you will get after the conference. So please don't worry to take too many notes or take pictures of the slides. All the PDFs will come to you at the end. So this is a study from the NEJM, which gives you the average thyroid function changes over the course of a postpartum thyroiditis, or any thyroiditis for that matter. And we start with a high T4 and a low TSH, with low iodine uptake, because this is an inflamed gland. So you're not actually having an increase in thyroid hormone production, you're just having secretion of preformed T4 from this gland, which is why no amount of antithyroid drugs are going to help you at this point. And over time, this gland recovers, and the TSH and T4 normalize. But in the course of that recovery, you may overshoot the mark, and for a short time, they may become hypothyroid until the point that they recover fully and become euthyroid. So just a few words on the postpartum thyroiditis, because it is relatively common, and it may be mistaken for any of the other conditions that happen in the postpartum period: iron deficiency anemia, postpartum depression. And we know that there's a lymphocytic infiltration of this thyroid gland, and it can occur in 1 in 10 women in the United States. We don't really have figures for sub-Saharan Africa. But the vast majority of these patients recover in 1 year. What is important to know, and this is the significance of those antibodies, is that this patient now has a predilection to develop autoimmune thyroid disease and develop hypothyroidism down the line. And within the next 7 to 10 years, not a vast majority, but at least half of them will. And over the course of their lifetime, many more will. So that is the significance of monitoring those antibodies. And you don't need to monitor them forever. Just to know that once the antibodies are positive during that postpartum thyroiditis, the risk is there. And should they present with symptoms down the line, it is necessary to screen them for hypothyroidism. So this is an overview of the common causes of thyroid dysfunction. I'm not going to go through it in any great detail, but as you can see, you will get this in your slide deck. Right, so the second case looks at calcium. So we have a 55-year-old lady who presents with fatigue and abdominal pain. Very non-specific symptoms. She's known with hypertension for many years, and she's being treated with hydrochlorothiazide and an ARB. And more than 10 years ago, she was diagnosed with breast cancer and has been in remission, and she's been well. But there's nothing much to find, but she really doesn't feel well. So you order a few blood tests, and we know of those that you've done, her renal function is normal and her vitamin D levels are normal. But you find that her calcium is almost 3. Now, calcium levels are a difficult test to do because they are influenced by a wide variety of things. Your acid-base status, your albumin level, but for the purposes of this, we're going to assume those were all normal. And the last thing, which is a common thing, is actual application of the tourniquet. And that stasis can increase your serum calcium by up to 0.3 millimoles. So, if you are concerned that this may not be a true reflection, it is worth repeating your calcium with an uncuffed sample. So, requesting an uncuffed calcium from your lab. Now, this is the long list of causes of hypercalcemia, and I'm not going to go through it with you, but this is the better way to think about hypercalcemia. Is it dependent on PTH or is it not? And in this particular patient's case, it's important because the top two causes, primary hyperparathyroidism and malignancy, are what we are going to be concerned about in her. Middle-aged women have the highest prevalence of primary hyperparathyroidism, and it is in this group of women that that also have menopausal symptoms, that also have a high risk in terms of malignancies. So there is often an overlap here, and it's impossible to differentiate without investigating them further. The other condition that is not listed there is a rare condition called familial hypocalciuric hypercalcemia. The reason I'm mentioning it is because it is benign, it is asymptomatic, and there is no treatment necessary. And the reason I mention it again is because it is important to exclude it, and I'll explain that a little bit further down the line. But we know that we have two common causes when this woman is a prime target for both of them, right? The other thing to mention is that she is on hydrochlorothiazide, and hydrochlorothiazide causes urinary calcium retention, but it is also known to unmask the presence of underlying primary hyperparathyroidism. So in patients who are on hydrochlorothiazide, it is worth looking at. There are several other drug causes, but that's the common one we need to consider, right? So I've decided to go through her vignette in two ways. First, if this was PTH mediated, right? You can see that her calcium is 2.98. Is this high, moderately high, or very high? And what is the definition of each? So the truth is there isn't a standard definition, but if we look at the guidelines in terms of treatment, a calcium that is more than 0.25 millimoles per liter above the upper limit of normal for your lab reference range would be considered worth intervening on. And remember I said that a cuffed sample can influence it by 0.3. So if you have a mild to moderately raised calcium, it is worth repeating the calcium rather than going on to more expensive tests. But the thing to note is that your PTH is raised, and it is raised to almost twice the upper limit of normal. And if we remember our negative feedback loops, we know that if your calcium is high, the PTH should be suppressed. If it's not, it means the PTH is driving that calcium. And so this is most likely primary hyperparathyroidism for all of the reasons listed on the previous slide: an adenoma, hyperplasia, even a carcinoma, very, very rare, I have to tell you. And the correct thing to do at this point, if you have confirmed that this is PTH-mediated hypercalcemia, is to localize where that is coming from. Meaning, is it an adenoma or all four glands hyperplastic? And you would do either an ultrasound by an experienced sonographer or a nuclear medicine image called the sestamibi scan. Note I said that the UNE was normal, and the reason I mentioned that specifically is because tertiary hyperparathyroidism is also a consideration, but that is a really long talk on its own. So for the purposes of this one, we're going to leave it out. And if this was PTH independent, it means PTH is not driving it, so your endogenous PTH should be low. It shouldn't, and we need to understand that while your lab may report it as low, it is appropriately low. So for a calcium of 2.98, your PTH being reported as low is appropriate and normal. You want your PTH to be suppressed in that setting to tell you that your parathyroid glands are normal. Unfortunately, it does mean that this is an independent cause, and it is most likely coming from that malignancy. And if it's coming from the malignancy, it's one of two places: either osteolytic lesions or as a paraneoplastic syndrome, the PTH-related protein. One of the take-home messages from this slide, though, is that in either of these cases, if you have gotten to this point, no matter which one it is, this patient needs referral. So my last case is on hypertension. And the reason I bring it up, not because endocrinopathies are feature very high up in the run-of-the-mill patients we see with hypertension, but because the prevalence of hypertension in Africa is so high. And the morbidity and mortality in untreated hypertension or inappropriately treated hypertension is particularly high. So it is something I thought would be useful because we see it so often. So we have a 43-year-old man who comes into the rooms. Sorry, there's a typo there. But he has come in for the third time. He's complaining of repeated panic attacks over the past year. And he says he's gone to casualty several times with these panic attacks. And every time he's gone in, he's had an elevated blood pressure. He's been treated with anxiolytics on a PRN basis. But when you see him, his blood pressure and his physical examination is normal. Now, the question is he, does he require investigation as a newly diagnosed hypertensive? And should he be investigated for secondary hypertension? So I could pick at someone I know or poll the room, but I think maybe in the interest of time, we'll just go forward, right? I do think he requires investigation as a newly diagnosed hypertensive. And I do think he should be investigated for secondary hypertension. We have at least 4 documented cases of high blood pressure, and it would be worth going back to those casualty admissions and finding exactly what the blood pressures were at that time. But he's clearly hypertensive based on the recordings of 3 to 4 casualty visits, right? Should he be investigated for secondary hypertension? Yes, I'll tell you why just now. But before I get there, I would just talk a little bit about the investigations of a newly diagnosed hypertensive, right? And these come from various guidelines, including the JNC guidelines, the American Association of Family Practice guidelines, and the European Society guidelines. But the point is that if you're newly diagnosed with hypertension, going onto an antihypertensive and not doing anything further is not sufficient, right? The most important thing, and I'm not saying this because Shoaib is chairing the session, is the urine analysis. The thing is, as much as I would like to pick up the rare and wonderful endocrinopathies, missing an acute glomerulonephritis is unforgivable. And it is a simple bedside investigation that can actually not just save the patient's life, but save them from a lifetime of dialysis, which is really, really important. But we know that metabolic syndrome is often comorbid with hypertension. We know that looking for renal abnormalities is important, and if you're going to start them on an angiotensin-converting an ACE inhibitor, we would need to check that UNE in advance, the calcium, the lipogram, all essential, right? So why should I investigate this particular patient further, right? This is a long list of causes of secondary hypertension. Again, we're not going to go into all of them. But what was special about that patient? This slide, again, you will get, which tells you all the clinical clues you need to look at. But according to the guidelines, the indications to investigate secondary hypertension are as you see on your screen. So if you had someone who was previously stable and is now has an acute rise in their blood pressure, absolutely. Anyone who is young. And that definition really depends on what your age is, but most guidelines currently say everyone under the age of 30 should be investigated. The presence of malignant or accelerated hypertension, and lastly, resistant hypertension. And resistant hypertension really means being on 3 or more different classes of agents, one of which is a diuretic. But what I want to point out to you there is I've listed the level of evidence. This level of evidence is important because there are no randomized control trials to decide this. These are practice points. This is based on years and years of clinical experience that has gone into putting these into the guidelines, but you're not going to find this in a trial. But I've added a few more that we have seen that are useful to remember because they do make a difference to how you will assess your patient. One is the presence of the clinical signs of a systemic disorder. Hypertension is an asymptomatic disorder. And if the patient has signs of a systemic disease, it is certainly something to look for. Patients who have an acute rise in their blood pressure, during surgery, any abdominal manipulation, and women during childbirth, they should not have exacerbations. And this is something that is definitely worth considering. We're thinking of pheochromocytoma here, right? Patients with paroxysmal hypertension, especially if they are associated with symptoms. And this is the patient who was in the vignette, had isolated episodes of anxiety associated with a raised blood pressure, but when he saw you, the blood pressure was normal. And they were severe enough that they took him into hospital, right? So that would have been my rationale for investigating him further. And then the presence of hypertension and hypokalemia if they're not on a potassium-losing diuretic. This one's not absolute because you can have primary aldosteronism with normal kalemia, but certainly if they are hypokalemic, then you have no excuse not to investigate. Right. So that is it for the case vignettes. I just want to talk about a few words in conclusion. So we know that the biochemistry is essential in assessing our patients properly. Thyroiditis is a common cause of thyroid dysfunction, but it is self-limiting. And simply monitoring the patient is sufficient to make sure that they are okay. But in those patients with positive antibodies, we should be monitoring them in the long term. Primary hyperparathyroidism is one of the commonest causes of hypercalcemia, particularly in the middle-aged female. The presentation is non-specific, so it is worth looking for in the appropriate patient. Lastly, in terms of hypertension, our initial history and examination and those baseline investigations, which are really important, are essential to assist in deciding whether this patient needs to be investigated further. So with that, I thank you for your attention. Shoaib, do we have time for questions?
Yes, that's why I'm up here, because Nasreen has very nicely stayed within the time. So we've got time for one or two questions. Just to make the question process more efficient, you've all got paper on your table. So maybe not for this talk, but for the next talk, if anybody wants to ask a question or thinks about a question, maybe you can write it down, and maybe Ahmed, I can ask you to collect them, and then we can bring them up. It may just be faster for the future sessions. But for this session, anybody have any pressing questions? I mean, I'm glad you brought up, hyperparathyroidism. I think it's a very undiagnosed condition. We commonly see it when the patient comes with end-stage renal failure, and calcium has been high sometimes for years. And you look at the cumulative result, and we've had patients where the calcium was documented as high 12 to 15 years prior. And that patient missed like decades of an opportunity to save their kidneys. So from our side, I mean, it's like a devastating a consequence of a very treatable condition. So I'm really glad you brought it up. Obviously, the obvious signs of kidney stones and so forth are not that obvious. Uncle Yusuf, you have a question? Or you're just stretching? Can we have a mic there, maybe? Okay.
So the guideline says 0.25 millimoles per liter above the upper limit of normal for your lab. So usually over 2.75 is something that requires investigation. So it's often patients with lower levels are asymptomatic. So it's worth repeating a calcium. So there would be two things in my opinion. One is that guideline of 0.25 above the upper limit of normal. And the second is persistent hypercalcemia. Patients should, even patients taking calcium supplements, even patients who have other reasons that your calcium, if you have normal renal function, should never be persistently high. So it is worth investigating. The other thing, and it's sort of slipped my mind now, is in the asymptomatic patient, should you be doing anything about it? And that's where there's a whole different set of guidelines about what to do with the asymptomatic patient. And if they have renal dysfunction, if they have osteopenia or osteoporosis, or if they have, if they start developing any symptoms, they need to be referred for investigation. I meant to mention the FHH, the familial hypocalciuric hypercalcemia. The easiest thing to do in that setting is to just check a urinary calcium. If the urinary calcium is high, again, this is likely to be primary hyperparathyroidism, and they need to be investigated.
Okay, just I think one of the things, our time's up, but just one of the things that a lot of people do is they do a PTH in isolation. And if you find a high PTH, I suspect that half the ladies in this room will have a PTH which is above the upper limit of normal. And often it's secondary hyperpara from vitamin D deficiency. So that's probably the commonest pattern that you will find. In fact, not just the ladies, almost half the people in this room may have that pattern.
Thanks, Shiv. I was actually going to add, I think it's everybody, but the high PTH secondary to vitamin D deficiency is common. But as a general rule, with endocrine testing, it's worth doing a paired test. Interpreting a result in isolation is almost impossible because we know it all works on a negative feedback.
And then just one last quick question. In pregnancy, I think this is from Yasmin, first or second trimester, TSH normal, low T4. Obviously, we know the devastating consequences of hypothyroidism in pregnancy, but the TSH is normal. How would you investigate? How would you treat?
A low T4 and a normal TSH?
Yes.
That's a long question, right? So first of all, I think for take-home messages, one
Refer.
No, not yet. So the one thing to remember is that your pregnancy reference ranges are different. So what you might think is a normal TSH may not be a normal TSH for that trimester. So I think that's the first thing to remember when you're dealing with thyroid functions in pregnancy. The second thing is normal TSH, low T4 could be a variety of things. It could be a patient who is on thyroid hormone supplementation who is not taking their altroxin on time. It could be the recovery phase of a thyroiditis. And the last thing it could be is pituitary disease. So you're actually looking at secondary hypothyroidism. So the TSH is normal, but it's inappropriately normal. So it really would require further investigation. So my advice would be to repeat. If this is not within a margin of error or not any of the other reasons, then you would have to refer.
Jazakallah. Thank you, Nasreen. That was a fantastic presentation. I think without further ado, we move on to our next presentation. If Dr. Hilaal Bobat could gently jog up to the podium. The next presentation is by Dr. Bobat, who frequently follows me around on ward rounds for an unknown reason. He's
This is good humor.
He's a colleague of mine at the Wits Donald Gordon, further trained in transplant hepatology, and is the current head of hepatology at the Wits Donald Gordon Medical Center. He's an honorary lecturer at the Department of Medicine, University of Witwatersrand, and a trustee of the Gastro Foundation of Sub-Saharan Africa. He's on the regional executive of the International Liver Association and a member of the International Primary Sclerosing Cholangitis Study Group. So I hesitate to say, but he's going to deliver a talk for us. Jazakallah.
That's why we have to follow him around. Nah? Okay, so assalamu alaikum everybody, and shukran to the organizers for the honor. I'd like to reiterate what Nasreen said, looking around and seeing all the mentors and seniors that beat the path from when I was undergraduate days. And of course, Nasreen, you were actually one of those. Where did you disappear to? You were there. She's gone. Okay. We were back at UKZN together back in the 2000s. And she was certainly someone that we all looked up to. So I know the program says it's an approach to liver disease. That's a bit broad, right? I think what I felt was needed was a focus on looking at metabolic associated fatty liver disease. This is a condition that is rising in prevalence internationally and is relatively poorly understood, with many patients actually presenting at end stages with features of cirrhosis, where it then becomes very difficult to subsequently manage. This is something that we see relatively commonly, where an individual goes for an ultrasound and features of hepatic steatosis. And what this picture is demonstrating is just that the liver here is brighter than the kidney here. You can see it somewhat darker than that. Enlarged liver with diffuse increased echogeneity suggestive of fatty infiltration. But it isn't just necessarily metabolic associated fatty liver disease that is going to give you this presentation, because by far in our context, alcohol is certainly there. It's relatively easy, though, to have a look and see which is which, though. By looking at in metabolic associated steatotic liver disease, you'll notice that you have an elevated gamma-glutamyl transferase a normal alkaline phosphatase, and then what is interesting is you look at your ALT and AST ratio. In alcohol, your AST is often twice what your ALT is. In metabolic associated liver disease, it's the other way around, where your ALT is in fact twice your AST. And you can see that then, and there's actually a better example later on in the talk. Here's where there was a bit of weight loss, but then once again bumping up in that sort of fashion. This is an unfortunate woman who had quite a significant alcoholic hepatitis and has then represented subsequently. And you can see, it is keeping quite nicely in that bracket that I had explained. So metabolic associated steatotic liver disease is a nice segue coming from an endocrinologist's talk, because this is a global metabolic problem. And it is not just the liver that is going to cause problems. In fact, in earlier stages, it's often extrahepatic disease that causes the issues. And, in terms of the liver, the steatosis, steatohepatitis, and cirrhosis, you have the hyperlipidemic aspect, peripheral and cerebrovascular disease. Obesity often results in sarcopenia, sleep apnea, malignancy, extrahepatic malignancy, HCC, your diabetes and all your various complications, hypertension and all your various complications. So it's a multisystemic condition, which it's also kind of proving hard once these patients have knocked off their livers and are now presenting for transplantation, because there's so many things going wrong with them systemically. They often need cardiovascular intervention that Ahmed knows very well about, possibly need a kidney at the same time as a liver that Shuaib knows well about as well. So because of these issues in terms of looking at alcohol and obesity and the twin pandemics that we're experiencing in the West, what the international societies did is look at the various criterions in order to better define metabolic associated steatotic liver disease. And what they came up with then is looking at the initial imaging diagnosis of steatosis, looking at your various cardiometabolic criteria, and this would be at least one of 5: raised BMI, impaired or glucose tolerance or diabetes, hypertension, elevated plasma triglycerides, or HDL being low. If you have any one of these with steatotic liver disease, there's a good chance that you're dealing with metabolic steatotic liver disease, versus if you're consuming alcohol, in which case you very likely have something called MET-ALD. So helps us being, with the Afrikaans background. So it's metabolic associated liver disease, MET, alcohol liver disease. All right? So these are individuals then where muscle predominance would be where they're drinking within criteria of anything from where this is in grams of alcohol per week or grams per day. 10 grams is approximately 1 unit of alcohol. So this would be within criteria. And as you progress, it becomes more apparent that it's alcohol-associated liver disease. There are other things that can cause the fat deposition in the liver. Wilson's disease, certain inborn errors of metabolism, hepatitis C, hepatitis B, malnutrition, and celiac disease are all possibilities. But this would take a little bit more digging. And I wouldn't necessarily recommend blanket testing ceruloplasmins and 24-hour urine coppers on patients presenting to your practice. I think hepatitis C would definitely be one of the things to exclude. So, like we said, there's a lot of patients out there with this condition. I mean, some people would say that about a third of the world's population has some form of metabolic derangement resulting in some form of steatosis. There aren't that sort of number of endocrinologists, hepatologists around to deal with that sort of thing. So there have been some form of risk stratification strategies looking at how best to manage these patients. Your first step would be to identify, are they diabetic, obese, confirm the steatosis, rule out your secondary causes, looking at prevention of your cardiovascular disease, and then a fibrosis risk stratification strategy should be performed. And that would be with a simple tool called the FIB-4 index. The FIB-4 index is a fantastic tool that will be on most MD Calc or whichever type of online calculator you use. It's basically looking at the patient's age, ALT and AST, punch it in, and you get a figure. If the FIB-4 is greater than 2.67, that's a high-risk patient. That is suggestive of advanced fibrosis. And that sort of patient should be referred on for tertiary level care. Anything from 1.67 to 2.6, that's a somewhat intermediate range. It's suggesting the absence of cirrhosis, but the presence of fibrosis. So sorry, less than 1.3 would then be low risk. And in terms of guiding you, in terms of what measures are you going to put in and how closely will you be following up these sort of patients. It is important to note that your consequences of fatty liver, as I said, are not just on the liver itself, but in fact, what you can see is in terms of the various problems, the dark line is F4 cirrhosis, with this being, I think this was F3 and F2. What they showed is that your major vascular would happen at F3. Extrahepatic cancers are more common before you're cirrhotic, with individuals that are cirrhotic having more problems around decompensation and liver malignancy. Weight loss is pretty much what we have to treat this condition. There are no real approved therapies, and it's recommended to lose anything from 10 to 15%. This is difficult to maintain, and there's the risk of yo-yoing. And what you can see is that only 10% of individuals after 52 weeks of intensive lifestyle intervention can actually maintain that sort of loss. But looking at steatosis improvement, fibrosis regression, and NASH resolution, that is the magic figure of where we need to be. Alcohol and MAFLD, like I said, it's a dual pandemic, and alcohol acts synergistically to metabolic-associated fatty liver disease. Even moderate alcohol intake has been shown to result in increasing your risk ratio. If you look at the hazard ratio here, if you are drinking above guidelines and are overweight or obese, you have an 8 times higher hazard ratio of developing liver disease. So in terms of management, and we need to look at our traditions and teachings. And I think it's important to look at the Sunnah of our Prophet ﷺ. He has said on multiple different hadith on health and fitness regarding things that I think are very apt to the management of metabolic-associated steatotic liver disease. Firstly, in terms of consumption, a human does not fill a vessel that is more harmful than his stomach. And this is especially true in the modern era where we're dealing with processed foods. Processed foods are designed for their addictive nature. You open a pack of Doritos, there's a special crunch, there's a special flavoring that makes them addictive. You want to eat more. There are other things in there that stop you from being sick from eating them. The fact that Coke has phosphoric acid in it is there to cut the sugar so that you don't immediately vomit it out. That's how much sugar is in it. So, these various processed manipulations in our diet these days are causing these sort of problems that are now coming to the fore. Furthermore, then, a believer who is strong and healthy is better and dearer to Allah than the weak believer. And obviously now, you can draw a parallel to individuals who give charity. The hand giving is better than the hand receiving. So this isn't necessarily a judgment call on individuals who are ill or who have other problems, but when you are healthy, to focus on utilizing your body in a correct fashion and according to Sunnah in terms of health and training and physical exercise. But in general, if this isn't, if this is Mr. Fenter or someone like that sitting in front of me and I have to explain that they have to stop drinking, what other measures do? I firstly send to a dietitian and I recommend that they start an exercise program. It's important to note that one of the ways of improving insulin sensitivity is by increasing muscle mass. That gives a place for the insulin to act and will improve your insulin sensitivity. Reduce your fructose consumption. Prepared fruit juices specifically. If you want fruit, eat the fruit, don't drink the fruit. This is where some people get confused about smoothies and so on, and liquidizing fruit, because that is a higher hit of fructose, especially into your system. Do your fibrosis assessment early on, and that can either be with a FIB-4 or, if you have it, transient elastography. There are other modalities of assessing liver stiffness that are coming available on newer ultrasound machines. And then look at managing their comorbidities. It would be important to vaccinate these individuals against your various other hepatitis. Hepatitis A especially, it's something that we never really used to see in the more affluent areas of this country. We're now seeing older individuals getting quite ill from contracting hepatitis A at later stages, and especially if they have existing fatty liver disease, this can put a significant strain and tip them into acute liver failure. The COVID vaccine, of course, we know about the metabolic risk factors there, and then don't be afraid of statins and liver disease. Statins, I think, have been overplayed significantly in their role with causing a hepatitis. You can expect some degree of accommodation with the statin, but we are increasingly using statins even in advanced cirrhosis because there are benefits, just as with the heart and myocardial circulation. There are benefits in terms of mitigating portal hypertension in the liver. So, as I tell them, a 7 to 10% weight reduction. I often tell them it's aerobic and resistance training. No real specific diet has been recommended. Other clinical trials looking at hypertension and so on often recommend the Mediterranean, and it seems that our guidelines have kind of gone along with that, which is high in fish, fiber, veg, low in cholesterol, and low in sugar. Coffee consumption, anecdotally, it isn't anything that is hard evidence-wise, but there are a number of small studies looking at the benefits of coffee consumption and liver disease. There's also benefits of coffee consumption and cerebrovascular disease, Alzheimer's, etc. So we encourage them to take in 2 to 3 cups of coffee per day, no alcohol in cirrhotic patients. Once again, this is just the benefits of exercise in NAFLD, looking at peripheral insulin sensitivity, decreasing visceral fat, and then various positive changes in the cardiovascular system. Pharmacotherapy, there is no drug approved for metabolic-associated steatotic liver disease. If they are diabetic, you have certain options. The existing data coming from the PIVANS trial about 10 years back looked at the use of pioglitazone and vitamin E. I personally don't really like vitamin E all that much. It needs to be given in a dose of 800 international units per day. This will increase a male's risk of prostate cancer, and it has also been associated with cerebrovascular hemorrhages. So I think there are currently better options for us to use and to target. Most notably, looking at the GLP-1s, which I know my colleague Dr. Zia Bayat will be talking about later in this meeting. If they are diabetic, SGLT2s are not proven to help fatty liver disease alone. I'm not going to say that. The two of these don't really help fatty liver disease, but have other benefits, including metformin in terms of its antineoplastic effects, antineoplastic and antifibrotic effects, the SGLT2s preventing your complications of your cardiovascular and renal pathologies. If you are not diabetic, you can consider vitamin E. You can talk about it. I'm definitely not going to push it, right? But it's mainly the GLP-1 diet and lifestyle. There are other bariatric pharmacotherapeutic agents out there that some people go on for other agents. Most commonly, I think, is topiramate, right? There's no data on the use of topiramate for histologic inflammation and fibrosis, but there are some, there is good data from the US in conjunction with drugs such as phentyramine, looking at its weight loss potential. And that's kind of really what your target is. Bariatric surgery, BMI more than 40 with comorbidities, these patients need to watch out for alcohol use. When they have that gastrectomy and rapid transit of alcohol through their system, the injury is potentiated. 1 unit equals 2 or 3 units to a normal person because of the lack of digestive capacity within the stomach and various psychological problems that some of these individuals have when they have bariatric surgery. But it certainly does improve your major adverse cardiac events and improves liver outcomes. So it's not something to be discounted. What is of note is that once you have F4 or cirrhosis, there doesn't really appear to be all too much of a change. However, when you look at other stages, you do have significant regression of fibrosis in these patients that have had bariatric surgery. There are a number of future therapies coming on the market. Drugs that can help resolve steatohepatitis, drugs that are overall better metabolically and improve glycemic control, drugs that prevent progression of fibrosis and then reduce fibrosis. And what you can see is that there's a number of trials in various stages. Of interest would be the semaglutide. This drug is not approved to treat NASH, but has the most rigorous evidence looking at NASH resolution in patients with fibrosis. It showed that there was no fibrosis regression, but that was possibly a slightly too short a time interval, and there's longer studies looking at the use of semaglutide in patients with NASH. This is a colleague that went on it, and you can see how badly inflamed she was, looking at that ALT-AST ratio, maintaining being elevated. I didn't include her alkaline phosphatase, but that was normal. Pretty much 6 weeks after starting the semaglutide, and that is what she normalized down to. So she had a fantastic result after losing approximately 10 kilograms in those 6 weeks. There are second generations such as tirzepatide. I'm not going to labor this. I'm sure Dr. Bayat will. But then you have the PPAR agonist, peroxisome proliferator, activated receptors, both alpha and it should be gamma. I know my Greek alphabet's incorrect there. But your PPAR gamma is expressed in hepatocytes and improves insulin sensitivity. Thyroid hormone receptor agonists, this is a drug called resmetirom. This is acting on a thyroid hormone receptor beta, which is the hepatic subtype, so you don't have the toxicities of systemic thyroid hormone. It's focused on the liver, and it clears then your hepatic fat and improves metabolism. So there's a number of things there. I think this is my last 2 slides. So in terms of managing the cirrhotic patient, HCC screening, these patients develop HCCs at a higher rate than normal. If you have suspected advanced fibrosis, you do not necessarily need a 6-monthly HCC screening. If there's anything odd looking at various nodules, CT, MRI for that, look at optimizing their metabolics. That's it.
Thank you, Hilaal, Jazakallah, and thank you for keeping into time. I don't know if my presence influenced you. I apologize for that. The take-home message for me is that if the liver is brighter than the kidney, it's pathological. And I feel the same if the hepatologist is brighter than the nephrologist, it's not normal. Okay, so this is a question. What is the cause of a slightly isolated ALT or isolated raised AST in healthy patients? Those are 2 different questions, actually, Hilaal. What a slightly isolated ALT may be down your alley, and a slightly isolated AST, maybe they're drinking something or taking
not
something.
Necessarily, one of the common things is that I see patients that are young, fit, like teenagers that are gymming a lot, right? Remember that everyone speaks of AST being in muscle, but there is also ALT there as well. And they go for a checkup for Roaccutane or something like that, and suddenly they have a rip-roaring hepatitis, right? And you look at the LFTs, and you can get them in the high hundreds, just under 1,000. You just need to ask: are you training heavily? Do a CK, discharge, follow up in a week.
Okay. The next question is, what about the benefits of intermittent fasting to treat fatty liver?
Still being looked at. It is one of the options. It's not recommended for or against. Again, if you start looking at prophetic guidance from the Hadith, intermittent fasting Mondays and Fridays is recommended.
Thursdays.
Mondays and Thursdays. No, right? Your white days, etc. So yeah.
And then the same WhatsApp group, obviously, the effect of keto or Benteng diet. I think. One of the things that I would like to know from my own perspective, because there's this concept that fatty liver is caused by the conversion of sugars to alcohol inside the liver or through the GI tract. Is aggressive carb reduction warranted in these patients? So that's where this keto Benteng thing comes in as well.
So in terms of autobreweries, that is where your gut bacteria,
microbiome, yeah.
Your gut microbiome. There are a few of those patients. That's not one of the more common means of the fat deposition. The fat deposition is by far a energy excess being converted into hepatic triglyceride.
And then 2 last questions: the role of NAC and the role of silymarin.
Silymarin or milk thistle has been looked at and was thought to be of benefit. It has theoretical benefits, but it has not proven to be either beneficial nor harmful, other than on your pocket and buying it. All right? So that's milk thistle or silymarin. N-acetylcysteine is something that we do use. It gives glutathione to the liver and allows for the various second and third phase reactions that occur to, in terms of production of reactive oxidation species in order to be dampened down and provide a substrate.
So how do you give it, Hilaal? As a chronic, like once a day thing, or as needed, or when you're stressed, or when you have a braai? How do you do this?
So if you're going to use a supplement, that is the one that
And it's cheap.
And it's relatively cheap. That's one of those that if a patient is absolutely insistent.
So if you're gonna take a cough syrup, that's the one to take, not Benylin with alcohol, guys.
That as well, because that one has alcohol.
No, don't take the Benylin. Okay, and then one last question. Time's already up.
There's an epidemic of fatty liver, and my colleague next to me is radiology. He says he's been finding if half of us we do a scan, we'll have fatty livers. And the reason he says that's being done is because of the processed foods which you alluded to and the sugar. And in the sugar is not the glucose, but it's the fructose that's actually toxic and causing. And he says, as a pediatric endocrinologist, he's picked up 25% of the US children have fatty livers and not related to alcohol at all. And the treatment, he says, it is purely our food. In other words, the food, the closer to the ground it is, unprocessed, and if we give fiber so that you feed your microbiome, you actually then prevent this fatty liver. And he strongly feels it is more to do with food and less to do with drugs. Unfortunately, the farm industry and the food industry are so powerful that this message doesn't come out clearly enough.
I think that's what Bilal alluded to in his slide, that we have strong traditions within our prophetic tradition, within the example of our Nabi Sallallahu Alaihi Wasallam, which give us lessons on how we should be living our life. And then we're developing drugs to sort of mitigate the effect of our poor lifestyle and the loss of our perspective on how we live our lives. Bilal, any final words? I'll give you the final words since you're wearing such a nice topi.
100%, that's exactly the point. But the problem is that the neurohormonal balance that adjusts growing up in that environment and in that system requires things such as your GLP-1s. This is one of the reasons that, you speak to someone that's overweight. Have you tried to lose weight? Yeah, I have, and I failed, right? And this is where pharmacotherapy is going to be required. Things such as bariatric surgery, that sort of thing.
Jazakallah. Thank you, Bilal. That was a fantastic talk, and I think lots of things for us to digest around there. Not sugar containing. So make the healthy choices at tea time and lunchtime today, inshallah. Our next two speakers are going to do a duet for us, or a team talk. We have Dr. Salim Chunara and Dr. Ashraf Wadi, and they're going to be talking about global cancer screening guidelines. Salim is a co-member of the Islamic Medical Association and very involved with the planning of this convention. And he's a specialist urologist based at the Netcare Millpark and Garden City hospitals. He has completed a fellowship in training in laparoscopic surgeon at the World Laparoscopic Hospital in India and the University of Strasbourg in France. He is part of the renal transplant team at the Millpark Hospital. His special interests lie in the application of advanced, minimally invasive and robotic surgical techniques in the management of urological cancers. I was thinking of getting married now. He is passionate, his mouth. He is passionate about urethral reconstruction, especially related to children with hypospadias. So welcome, Salim. And then Ashraf, of course, his main qualification is he's a wadi. And, but he graduated from WITS in 1999 and continued with his postgraduate FCP and medical oncology degree. He's a medical oncologist in private practice at Wits Donald Gordon Medical Center and a teaching consultant at Charlotte Macleke Johannesburg Academic Hospital with ongoing participation in undergraduate training. He sits on multiple tumor and advisory boards. Welcome, Salim and Ashraf, and we look forward to something engaging and exciting from you.
Jazakallah. Thanks, Shoaib. Assalamu alaikum. Thanks to the organizers for tasking me with something relatively simple to deliver the current global screening guidelines for malignancy. And as usual with an oncologist, we'll start off with the bad news. This is where we currently are sitting with our global statistics. More than 18 million people that are detected each year with malignancies. At least 10 million people a year dying from malignancies, and about 20 million people living with cancer worldwide these days. And the value of the guidelines is to get that 10 million people dying from the cancer down each day. Our value of guidelines really lies in trying to decrease premature death, but of obviously and of course the potential harms and benefits to screenings that may not be regulated. Cost is an important issue. False positives and false negative results are a problem, and overdiagnoses for some cancers that would not ordinarily cause mortality, specifically with prostate cancer, is an issue. The other importance of guidelines is for consistency. We know between, or at least in one fraternity from our experiences in COVID, that consistency is key when having guidelines. And we currently support screening for breast, cervical, colorectal, and lung cancers. And the majority of the framework comes from the United States. Just to go through the grades of the guidelines that we have, there are 4 main grades, A, B, C, D. In fact, there's a recommendation I as well, which we'll get through. And a grade 1 recommendation is basically one where there is a high certainty that the net benefit is substantial. Grade B is where that certainty of net benefit is moderate, and both of these grades should be offered as a service. A grade C guideline is one where there is a benefit, albeit a small benefit, and a grade D recommendation where there's no significant net benefit. There's a grade I recommendation, which is more of a statement rather than a recommendation. And there, the current evidence is too small or insufficient to assess the balance of benefits and harms. And if the service is offered, ideally should not be offered. But if you're giving something with a grade I recommendation or a statement I recommendation, then the patient should be made aware of the uncertainty of the test. So probably the most widely used screening is for breast cancer. We do have self-breast examination and clinical breast examinations, which form the mainstay of breast screening. But the current guidelines suggest that women between the age of 40 and 74 who are at average risk for breast cancer have a mammogram every 2 years. Recently, the task force team has dropped the age down to 40 for women who could consider having a mammogram, but again, this should be done together with shared decision making with the doctors, because we need to weigh the benefits and the risk of screening. Clearly, mammography, and we know, designed specifically to look for breast disease, and these can sometimes detect disease which are clinically evident up to 3 years before they become clinically evident. We also use mammographies to track changes in breast tissue and to help us in guiding treatment when cancers are present. There's a grade B recommendation for mammography, and this again is only in patients from the age of 50 to the age of 74. What are our risks for over screening our patients? Our false positives are important because about 50% of women who get annual mammograms over a 10-year period will have a false positive. And that was probably the finding that led to the most controversial change in breast screening over the past 5 years. Breast screening or mammography was usually advocated yearly, but it has now become biannually. So that's every second year for a woman aged between 50 and 74. False negatives are important because obviously those delay diagnosis and treatment. And screening mammographies, despite their sensitivity, will still miss about 1 in 8 breast cancers. The question we get asked most often by our female patients is, what about the radiation exposure by mammography? And really the radiation exposure is minimal. For a typical mammogram, about 4 millisieverts. And to put that into perspective, for both breasts, that's about the same amount of radiation that you would get from your natural surroundings over a 6 or 7 week period. Cervical cancers is an important cancer, particularly in underdeveloped countries, and we know exception in South Africa. We have a number of tests, and this is a grade A recommendation because this test has shown to increase survival for patients who are screened and found to have early malignancies. Again, we have either HPV testing by themselves or co-testing together with a pap smear. But even if patients wish to avoid the invasiveness of a PEP test, they could undergo an HPV test only. Colorectal cancers, again, one of those cancers in which screening and early detection has shown to improve survival. So a grade A recommendation for these. And the recommendation here is that patients, or rather anybody eligible from the age of 45 to 75 be screened for colorectal malignancies, that is average risk individuals. Patients younger than age 45, if there are inflammatory bowel disease or conditions which lend them to an increased risk for malignancies, could be considered for screening earlier than age 45. So within colorectal cancers, there are different grades of recommendation based on age and based on predisposing factors. But just to recap, 50 to 75, everybody should have at least one screening modality for colorectal cancer. There are a number of screening, validated screening modalities that we could use. And again, to be able to accommodate patients' preferences, we have a number of invasive and non-invasive screens that we could consider for patients with colorectal cancer. The implementation is important in our elderly population because at the age of, beyond the age of 75, we need to discuss what the patient's preferences are for screening. We need to take into consideration what patients' overall health status is, what their life expectancy is, what their comorbidities are before subjecting these patients to colorectal screening. Lung cancers, a grade B recommendation for lung cancers. Again, these are only for adults who are currently smoking or have quit within the past 15 years and have a 20-pack year smoking history. The recommendation is for a low-dose CT scan annually. And if the patient has not smoked for 15 years or has a health problem that limits life expectancy or the ability to have lung surgery, then we can consider and not continuing with screening. The prostate cancer screening we'll leave for Salim to talk about. I just want to go across and just highlight quickly a quick recap of what we saw. So really the only grade A recommendation for screening currently is for patients aged 50 to 75 for colorectal cancer and for people aged, not patients, sorry, for people aged 21 to 65 for cervical cancer. Grade B recommendations for breast cancer, which would come as a surprise for most of you, and perhaps that's a contentious and a debatable recommendation that we'll talk about or debate a bit later on when we have some time for questions. The grade D recommendation is where we have absolutely no benefit for screening, and we should not be offering this to anybody. Pancreatic screening, cervical cancer screening in young patients or elderly patients, prostate cancer screening in men over the age of 70, and ovarian cancer screening in asymptomatic females, together with thyroid and testicular cancers. I want to have a little, I just wanted to bring this to, this is not screening, but many of us, unfortunately, take to using tumor markers for screening. And simply we know that these are molecules that can be detected in plasma and body fluids. And these are not primary modalities for cancer diagnosis. I think far too many of us are using them. They should be used and can be used as laboratory tests to support the diagnosis. And they can be used to monitor treatment responses. There are many reasons why these antigens can be produced, and they're not always malignant. They lead to an unnecessary amount of investigations, increased amount of anxieties amongst patients, and currently we should desist from using them as screening tools. So that was just in a nutshell, very briefly, what the current global cancer screening guidelines are. And Salim is going to talk to us a little bit more about the prostate cancer screening guidelines, which are a little bit more controversial.
Assalamu alaikum, respected colleagues. I'm very pleased to have shared the podium with our esteemed oncologist Ashraf. Our kids are also good friends, good colleagues, and they are very close as well. I've been told very specifically, when I'm on the podium, I must give a shout out to everybody that's watching us on live streaming from Polokwane. So I'm just doing that. But I'm very pleased to be part of this audience as well. Alhamdulillah, we have esteemed professionals, urologists, all kinds of academics in our midst today. And just as part of the IMA, I just want to say that it's really a celebration of Muslim health professionals. When we see what's in front of us today, the quality of the presentations and all the academics and just the information has been presented here today, alhamdulillah. It's quite a celebration just to be part of such a gathering as well. So yeah, so prostate cancer, screening for prostate cancer. I mean, obviously very controversial, and there's a lot of pros, there's cons, there's a lot of information around it. And I mean, the media also. I mean, prostate cancer is very big in the media, very big in social media. Screening sort of programs happen very, very widely, actively. Many cancer societies do that. So I think it's important just to have an understanding of what's the consensus, where does the information, what's the agreement, or where do we disagree on, and what do people really do in clinical practice? I think that's an important thing. So we also know that the reason why there's some controversy around this topic is because generally prostate cancer is a slower growing tumor, and treatment outcomes are actually excellent. I mean, the cure rates are maybe over 90%. Survival of patients with prostate cancer exceed most other cancers. So the recommendation is pretty much a grade C recommendation. The other issue, obviously, is that the issue regarding the PSA. I mean, there have been studies done in the past looking at other biomarkers. There was a PCA3 which came out with a urinary biomarker. But at the end of the day, I think we can still accept that some of the facts about prostate cancer screening is that the PSA is still pretty much advised. If we're going to be screening individuals for prostate cancer, then the PSA is still really the tool that is used in these individuals. So one of the other criticism that came out with regard to screening is the issue about the number of individuals that need to be screened, the number of individuals need to be tested, and how many people really benefit out of it. So initially, I mean, those figures were pretty high. But I mean, if you look at the some of the data from the European ERSPC study, the 16-year data, the amount of individuals that needed to be screened and that benefited obviously has come down over the years. So the backstory to that is that initially you're looking at probably in the early 1990s when the large trial in amongst the Europeans, and then there was this large trial in America, the PLCO trial, and in that study the Europeans found that there was a 20% benefit in prostate cancer mortality in patients that were screened, and the Americans disagreed with that. So I think if we just sort of find a consensus position there, we can accept that the benefits of PSA screening has caused a reduction in prostate cancer mortality and in the metastatic rate. I think that we can agree on. But where I think the criticism comes now is that the side effects that may come about because of overdiagnosis and overtreating these individuals is where the fraternity may face some criticism. So I think in an effort to mitigate some of that criticism, what is important to understand is how are we going to apply this modality in a better way. So what has come about is understanding of risk stratifying risk groups who are more at risk, and identifying those individuals, and then practicing a screening schedule that's individualized to those patients. Also, the screening interval, not simply testing these patients every single year, but adjusting it based on the patient's risk profile is something that's coming out in many of the guidelines, many of the bodies that are promoted, that talk about prostate cancer, the urological fraternity, etc. So, as I said, the issue with screening was obviously the false positive results and the issue of overdiagnosis and overtreatment. But my feeling about the overtreatment is that it's still very relative to the individual, the clinician, and the patient. It does not mean just because you have, and just because you've diagnosed with prostate cancer, every single prostate cancer goes from diagnosis into the OR or into a treatment modality. You don't have to do that. And I think the concept that's trying to mitigate the issue of overtreatment is what we call active surveillance, which is definitely gaining a lot of popularity even in literature and even in urological circles, to say that in somebody that has prostate cancer, you diagnose it on a biopsy, whatever the backstory was to that. The point is not every single cancer needs to be actively treated. And I think that point of active surveillance may be dampening some of the criticism that is leveled against just widespread screening, because those patients can be observed, can be monitored quite safely for years in many cases, and treatment can be instituted when appropriate changes may take place. And obviously the benefits of screening, as I said, I mean, a decrease in mortality certainly. And obviously because of the media hype, I mean, these are just guidelines, but I mean, I think the youngest patient I seen in my practice with prostate cancer was 37 years old. And I really walked in there and just said, look, I just had myself checked because my father had prostate cancer. We got a strong history of cancer in the family, and I just want to have myself tested. And when you're faced with that kind of situation, and that's exactly the point. The larger point that's come out in the literature now is something called shared decision making, SDM, which it is abbreviated as, meaning that when you face with an individual that wants to be screened or wants to be tested, it's very important to discuss with that individual. So let me make the difference. Let me just make a difference between screening and diagnosis. So screening, patient walks in there and wants to have just have a PSA check because they saw a program or they heard from the Cancer Society, you have your prostate checked. But I think what's important as clinicians now is not just to say, okay, it's fine, I'll just give you a lab form, go and do a test, and I'll see you again in a year's time. No, I think maybe the more better approach, the more accepted clinical approach would be to say, make that individual understand that what would be the implications if we start finding changes in your PSA. Do you understand that perhaps you may have to have further tests? You may require an MRI, maybe you require prostate biopsy. What happens if you find cancer in you? What happens and what are the options going to be available to you, etc. I think that kind of understanding where there's this awareness of an individual so they know what they're getting into will, I think, lessen some of the criticism that may be faced against just widespread screening. So that's my view on that. So I thought we just identify some risk factors and bring it together when I just show you some of the consensus guidelines. So certainly age is a risk factor for prostate cancer. Race and ethnicity, certainly a higher incidence in the African ancestry, definitely no question about that. Family history, this is obviously quite significant, and obviously the genetics, especially in those individuals where there may be a family history, Lynch syndrome, other genetic mutations such as BRCA1, BRCA2. So again, this is the point I was making about the shared decision making. When you sit with an individual, it's not just about giving them a lab form and say, go and do the test. I think good clinical practice would be to say, let's talk about you. Let's understand you. What's your risk factors? What's your family history? Do you have family history of cancer, other cancers? And understanding also the genetics behind it, which is something I think we don't always look at, but it's important to understand in how we're going to deal with these individuals. So I think what I put on the screen here now, and I'm sure it'll be open for discussion after this. I think it's just a sort of a consensus amongst many of the organizations and many of the urological groups that talk about screening for prostate cancer. So for one, we do agree that not for under 40 and over 70 years. I mean, screening by and large, the consensus is that it should be between ages of 50 to 69. But I just want to draw the attention to this point here. So there are some organizations, some groups that are saying that maybe what's advisable is a baseline at 40 to 45. Just a baseline test, where the individual's PSA is, where their prostate is operating. And based on that, one can then decide on what the interval for testing should be. But as far as the family history of prostate cancer, especially with their germline mutations, then that recommendation does go down at, like I said, from age 40 already. And from 45 to 50, there is some consensus that there should be a baseline just for maybe let's say the general population. Initially, we always thought about an interval of 2 to 4 years, but there have been some studies which have shown that in men who are under 40 and have a PSA less than 1, or in men that are sort of under 60 with a PSA less than 2, that schedule can even go up to 8 years, as long as that. There have been some studies that have shown that. But generally, I think the accepted interval is like 2 to 4 years. But again, the point I'm trying to make here is that, there's such varying inputs from different, I would say, fraternities in the urological circles that talk about screening, talk about prostate cancer, etc. And we add to that the massive social media hype around prostate cancer screening, PSA testing, that one will have to have a discussion with your patients. These are just simply guidelines. In clinical practice, you're going to find patients that are going to walk into your office and going to definitely entertain this question about having a prostate check. So I think a responsible way to approach it is maybe where that sort of middle ground would be found. As I said, the concept of shared decision making and understanding that it's preference sensitive. So those are important aspects. So in conclusion, what I'm going to say is that screening is important. I always like to think of prostate cancer as a disease of extremes. The cancer picked up early can be treated very, very well and with excellent outcomes. But prostate cancer picked up at a later stage has very, very poor quality of life associated with it. Recognizing the risk factors, this is very important. Again, coming out in a discussion. Also, the understanding that in prostate cancer nowadays, there's a revolution in how we treat prostate cancer, from radiation techniques, surgical, robotics, pharmaceutical, whatever. I mean, one can manage these patients exceptionally well. Even those with metastatic disease, I mean, the explosion in use of alternative chemotherapies, etc., is amazing, and patients do actually phenomenally well. So I think I just wanted to provide that as a broad framework, as an understanding. Inshallah, we hope to have a further discussion around it. Thank you for your time.
Jazakallah khair. I think that was two excellent presentations rolled into one. Maybe we can just have a discussion between Ashraf and Salim, and any questions that you would like to give them. I mean, what's happened to the digital rectal exam? Being given the finger.
Yeah, it depends which finger. Yeah, the shortest one. So no, it's definitely not part of screening. I mean, it shouldn't really be part of screening.
I mean, when I was in medical school, we were taught that you do the DRE and the PSA as part of screening, but
yeah.
Obviously there was lack of enthusiasm for it. But
I think we'll just get nobody will come and have a PSA check.
Yeah.
If that's going to be enforced in every single individual. But I think that the point about finding an abnormal PSA, again, even when it leads to, let's say, a biopsy, for example, there's a whole lot of modalities that one should then, carry out, such as a rectal examination, ultrasound, MRI, other biomarkers, etc. So before you even get to a biopsy, you've done so much already, in allaying that patient's fears and making a concrete decision about who should be biopsied. But to answer the question, no, a DRE shouldn't be part of screening.
This is a mammographer.
Assalamu alaikum wa rahmatullahi wa barakatuh. Jazakallah khair to both of you. I'm itching to ask a question and make a comment. So I think for a South African community, we have to decide whose guidelines we're going to and perhaps form our own because of the clinical approach. I agree with you, Salim. We, in breast radiology and cancer detection, we're having this similar challenges. But as a radiological fraternity, we have come together and have some kind of consensus of how we screen because of the practical considerations and what we're seeing in clinical practice. Ashraf, I'd like to ask you, what do you think of the task force screening guidelines as far as breast cancer?
Yeah, look, so I think if you ask an oncologist, the change into biannual, that means every other year screening, is way too infrequent. There's a big push from oncologists and from people who deal primarily with breast health to show, and the studies, I think there was a study from the University of Michigan which showed that the annual mammography rather than the every other year mammography picked up breast cancers, and the staging at which patients were picked up were earlier, and the need for interventions were also earlier. So a lot of patients were able to avoid chemotherapy because their stages were 1 or 2, or rather than a stage 3. So I think it's skewed. Again, if you ask me, I think it's every second year is too infrequent. But I may be biased because I'm working in breast health care. The difficulty is that funders will only fund unfortunately, what the guidelines state. And right now, funders have taken to funding only every other year mammography, unless motivated by ourselves for yearly mammography.
So, yes, I agree with you. And just to say, the task force is actually, there are many non-medical advisories on the task force. It's really a financial advisory rather than a clinical advisory. So we have to decide as a community in South Africa if we were going to take the US task force as our, dictators of guidelines as well. Thanks.
Okay. Any other questions? There's a speak.
Sorry. Can you comment on the use of this REZUM therapy, REZUM therapy for enlarged prostates? It's being done in Durban.
I actually had 2 patients that had it done in Spain, and they came to see me, but I think were very, very poor results when I actually saw them. So it's not something that I actually do in practice, but I just saw 2 patients that had really, really poor outcomes with it.
What is it, Salim?
So it's basically for the prostate. It's almost like water vapor type of therapy that they're using. Is that correct? Yeah. I
So
don't
they're
have much
blowing
experience
smoke
with
up your. Okay.
Something like that, yeah. You know,
Apologies.
The point about the prostate is that, I mean, you know, I think it depends on in whose hand it is. You see individuals that may practice that kind of therapy. They're good at it. They may have a good outcome. Then you get guys that are doing laser and they're actually good at that. And then individuals that are perhaps just doing your conventional TUR using the Tudor system, which is actually a very, very good system. Practices quite extensively international as well and getting good outcomes. So I think, again, it always comes down to the clinician and the patient and what's good in your hand. I don't have much experience with a specific one, but I just do remember seeing 2 patients. They just had very, very poor outcomes. In fact, in those 2 cases, we actually did a re-TUR on them, using the conventional system to get them urinating better. So that's been my minimal experience with resin.
So Shiven Ramkusan in Durban is doing it at the Capital Hospital. And he actually swears by it and he says that the results are very, very good. So I just wanted your opinion on that.
Yeah. If you speak to the radiologists as well that are doing embolization as well for the vessels in patients that have issue with BPH, again, you talk to them anecdotally, they say, yeah, I'm having very, very good results. And I think, you can go across every modality and I think there will be good result. My view on it is that it depends on who's doing it in an experienced hand. I've seen guys in centers where like in Europe as well that are doing the laser and they're so efficient, so fast, probably quicker than what we could do, a conventional TUR, and the patients get good results. So, in my practice, when patients ask me those kind of questions, I tend to say, okay, look, this is what's available. This is what we do at my institution. This is what I've done, and these are some of my results. Or this is what I can give you patients to speak to about what I've done. And that's how I go with it, That's been my approach.
Okay, I think there's one last question because we're running out of time. This is for Salim again. What would be a significant increase in PSA levels in a year, which would be within normal limits, but where would the increase warrant referral? So there's obviously not using an absolute cutoff, but something that's emerging more and more in medicine is the trends.
Yeah, so obviously what you're speaking about is the PSA velocity. Interestingly, in the AUA guidelines, they're saying that clinicians shouldn't be using the PSA velocity as a means of identify those who should be who should have a prostate biopsy. But I must say, I do use that in my practice, PSA velocity, because just to give a very quick example, I mean, you could have a person could have a PSA 0.5 all their life, and then they come and see and the PSA maybe goes up to 2.5. What the lab reference ranges, as we see it, pretty much normal for their age. But suddenly they change in the PSA, especially if it's more than 0.75, even up to 0.9, some figures have been quoted. But if that's the change that occurs in a year in an individual, they may be at risk for prostate cancer. But this is the point about the difference between screen and diagnosis. If you face that patient, then you need to now apply other modalities, examine them, do a rectal examination. And definitely MRI is certainly been used. It's used extensively in Europe. South Africa, the issue of the funders again, so MRI can't be used for every single patient. But imaging those patients with a good quality MRI will really add a lot of value to what you understand about those patients' risk, whether you need to do a biopsy, and you can observe the patient, to do another PSA again, see where we're going, and make a decision on that.
Jazakallah. Thanks, Salim and Ashraf, for some wonderful, engaging discussion around this topic. We're going to move on to our final speaker. Our final speaker is Dr. Yasmin Goga. Yasmin is a pediatric clinical hematologist. She obtained her MBBCH from the University of Witwatersrand and then completed her FC-Peds. This was followed by a certificate in clinical hematology, a master's in bioethics and health law, and a diploma in pediatric palliative medicine. She has worked in the pediatric hematology oncology unit at the Nkosi Albert Luthuli Central Hospital, Durban, and is currently based at the Red Cross War Memorial Children's Hospital in Cape Town. Her areas of interest include benign and malignant hematology, including thalassemia and bleeding disorders. She has been involved in the South African Thalassemia Guidelines, SA Hemophilia Guidelines, the Hemophilia Registry, as well as the SA Palliative Care Guidelines. She is the current Deputy Chair of the Medical and Scientific Advisory Committee for Hemophilia. She has been supportive of efforts to improve patient advocacy, education, and empowerment of children's rights, and she's going to talk to us about palliative care, who, why, when, and how. Welcome.
Okay, assalamu alaikum to everybody, and thank you for the opportunity to speak to this very large audience in a nice and warm, sunny Joburg compared to a bitterly cold, miserable Cape Town. So at this point, you've had an intense morning, lots of science, lots of directives, lots of detail. And I think maybe there's something you might rather be doing, but for now you've got me in front of you. So here goes. So I've been a pediatric hematologist now for 20 plus years, and it has not been an easy journey. Why palliative care? Because there were many things I struggled with. I struggled with having to face families. I struggled with speaking to children and knowing that they were going to die. When I discussed this with Prof. Adhikari, who was our head of department for many years at UKZN, and I said to her, Prof, how do we do this? How do you say to a child, you are dying? And she relayed a story to me. She said she had a 9-year-old, and this goes back probably about 28 years ago, where there was no hope for transplant. And he asked her very frankly, Prof, am I going to die? And she looked at him. And for those of you who know her, you will understand the compassion that she just radiates. And she said in the way that she so typically would say, my darling, we are all going to die. And there was more discussion after that. So without ducking responsibility, what's wrong with medicine today, and there is a lot wrong with it, is that it's pre-dedicated on providing treatment, not necessarily on reducing suffering, and not always on solving problems. So what is palliative care? It's a specialty in medicine for people living with serious illness, not necessarily for those who are dying, okay? And the goal overall is to improve the quality of life for both the patient and the family. What's it based on? The needs of the patient, not the prognosis. It's appropriate at any age, appropriate at any point in a serious illness, and it can, importantly, be delivered alongside with curative care. So I think for those of us who have trained at VETS, many of us, and I'm not sure if they still do it, but we would have visited hospice as undergrads, and that would have been our first introduction. And I think that actually that's a very valuable introduction. But I want to reiterate that palliative care, one of the main principles, is that it affirms life, and it also regards death as a normal process. It seeks neither to hasten nor to postpone death. So some of the other important things is that we need, and Salim mentioned, shared decision-making. We need to understand who is this patient in front of us? What are their values? What are their preferences? We need to establish plans in accordance with their values and preferences. We also need increasingly to understand this is not paternalistic medicine anymore. It's not 40 years ago. Patients have autonomy, they have choice. Dr. Google is far more powerful than we can ever hope to be. And they have knowledge, right? But importantly, what's missing in our very, very busy lives is the time for communication. That takes a lot of time. So one of the main aims is to provide pain relief, relief from other distressing symptoms, and then importantly, it's to integrate the psychological, the spiritual, and the social aspects of care, and these are often neglected. Coordinating care works, I think, relatively well in academic centers. I'm not sure, not being in private practice, how well it works there. But from my own experience with ill parents, I get a separate script from a neurologist, from a psychiatrist, and from the physician, all trying to address pain. And then the orthopod professor is not happy. And it's like, I don't want any of this. So what do I do? Importantly, it integrates with life-prolonging treatment. And the main take-home message from this is support. So I want us to stop, because when we think of palliative care, we think, oh, it's only for dying people. No, 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 absolutely not. It's much more than that. So the first question really is, who needs it? And all of the people here do. whether it's the extreme prem neonate, whether it's your 60-year-old that's being looked after by Shweb with chronic dialysis, a recently diagnosed brain tumor, a child with leukemia, or an elderly parent with dementia. All of them require some form of palliative care. So why is it provided? Isn't this what we do? Isn't everything that we do aimed at relieving suffering? But take a few minutes. An average GP consult, according to UK standards, is 10 minutes, and they've been pushing to say, can we please have 15 minutes? What can we accomplish in 15 minutes? So at this point, medicine is often about a quick fix. What can we put a Band-Aid over? And I like the comments from earlier about diet, because I think that's critical, and we have to go back to that. But palliative care is underlined with two other important additions, and that's the spiritual and the emotional components. And these are not necessarily addressed with the biopsychosocial model that we are familiar with. So the next question really is, when? When do I seek this sort of palliative care team? Who's going to do it? Where and how? So at the beginning, depending on what your diagnosis is, you may not need any of it. But as a practitioner, you need to be thinking of this person as a whole person. When you have the person in front of you who's got triple vessel disease, and you're starting to think, is it amenable to stenting? Is it amenable to surgery? Or is it not amenable to any of those things? There's a trajectory here. And as your disease progresses, and as the interventions are able to succeed less, the reality is that your outcomes are going to be poorer. You are going to die at some point, and increasingly, you're going to need more palliative care support. So there are three main trajectories that we in palliative care kind of work with. The first trajectory is typically cancer. So you are diagnosed, depending on the type of cancer. There are a few where we know from the beginning that it's a short lifespan ahead and the decline is going to be rapid. But for the majority of cancers, there is intervention, whether it's chemo, surgery, radiotherapy. But at some point, that disease may come back, and it may be refractory. And at that point, we then will have a fairly quick decline. The next trajectory is typically with organ failure. So think of chronic renal failure, cardiac failure. You've got this kind of slow decline. You go on to dialysis, you get added medication, we add another drug for cardiac failure. But slowly your abilities to live a more full life decreases. So you have intermediate kind of disease with acute episodes in between. And trajectory 3, unfortunately, is going to be our reality. Because dementia and what we are beginning to see of it is going to be huge. And unless we start to think of this and how we, both as a community, as a society, how are we going to have the tools to be able to support those that we love, we are going to be in a very dark place. So trajectory 3, frailty or dementia, is the gradual dwindling. So stages of palliative care, I think this is important because often we look at the pink bit, the end of life care, and that's not palliative care alone. Palliative care starts from the time you see the patient as a GP, as a specialist, to the time where you actually need to lean on your palliative care team because the symptoms are actually now not tolerable. Whether it's pain, whether it's dyspnea, whether it's not sleeping at night. The other thing that I think is not addressed by us as physicians is the whole bereavement process. As a community, we may step in some way. But within our practice of medicine, unfortunately, the patient has died. We sympathize, we fill out our forms, we pray, and we move on. Okay? But what happens to that family? What happens to that child who's lost his mom or dad? Bereavement is actually part of us caring for that family. So where should palliative care be provided? Okay, so we're familiar with hospice. And I think we need to take a relook at this because palliative care should be provided absolutely everywhere. So whether it's in your GP practice, whether it's in a day center, within hospitals, and I think there needs to be a push at all levels, academic, state, and the private sector, to recognize the need for palliative care teams to work alongside the treating physicians. How do we do this? Okay, so there's typically 8 domains within palliative care. We look at the actual structure and process. We look at the physical. We look importantly at spiritual, religious, and existential crises, care of the patient at the end of life, the psychological and psychiatric, social issues, cultural issues, and of course, increasingly difficult, the ethical and legal issues. So like I've said, should be practiced at every level of care. You as a GP, you as an oncologist, you as a cardiologist. And then at the end of the day, there needs to be somebody else who is actually a palliative care specialist who can assist where your level of expertise comes to its end. So who is it provided for? Absolutely everybody. But how do we do this? Typically, and it depends, some people work in silos. That's a disaster. We've evolved from monodisciplinary to multidisciplinary, interdisciplinary, and we now sit at transdisciplinary. Okay? And this is actually where we should actually be sitting down. I was amused when Shweb said he follows Bilal around. But really, when I think of the old days at Barra, when that was our transdisciplinary meeting, outside having that cup of coffee, where all the consults were changed and plans were made, that was transdisciplinary in a very different form. But I think we need to move it up to another level. We need to actually put in these kinds of meetings as part of the service package that we offer to patients. That's critical in their care. Have the cardiologist, the nephrologist, the general physician together with the family for 15 to 20 minutes so that we sit together and they get one message out. Okay, so who does it start with? Ultimately, it starts with you, no matter who you are. What are the fundamentals in terms of providing palliative care? Trust, honesty, not so easy sometimes, compassion, and then shared decision making. So this is difficult. Speaking to people, saying to them, you've got a life-threatening disease, or you've got a disease where unfortunately we cannot cure you. These are difficult conversations. And it takes a lot for us to do these conversations, but ultimately we have to be brave enough to start them. This is actually a very good mnemonic and one that you should probably pin up somewhere. It's called the SPIKES approach to breaking bad news. And essentially we look at the setting and we want a private, comfortable, non-threatening setting. So it's important to think about who and where we say these, have these discussions. Perception. So we don't start off first. Take it back to the patient. Uncover what is happening within the family. What does the patient think? What does the family think? Invitation. Ask the patient, what would you like to know? What are your questions today? Knowledge. Explain disease in a simple way. Emotion. This is a tricky one. Because unfortunately, many of us ultimately practice consciously, well, more likely subconsciously, in some kind of defensive mode. Okay? Respect feelings. People may be angry. They may be in denial. They want to blame. It's not about you. It's about what they're experiencing at this point. Summarize, recap, and decide what's next. So I just want to share a story with you. So Paka was a 10-year-old. He had a high-risk ALL. He hated IV lines, and in state you don't always have access to central lines. Hated admissions because he stayed alone in hospital. His chances of survival, I knew, were slim, but we needed to do our best for him. He was an only child. Mom was young, unsupported, had only recently found work, no ID document for herself or for him, and generally she was difficult to contact. He had relapsed. He was now requiring weekly transfusions. His white cell count had increased to about 300, and he had had platelets 3 days ago. So what were my team's responses? It was either, oh shame, poor mum, or it was, she's not responsible, she doesn't want to bring him in. So he was admitted with a hemoglobin of 2, bleeding and infection, was transfused, continued to bleed, and this is where it started to get difficult. So on the one hand, I had requests saying, can we please give him platelets, and at least I can get him home. He had significant epistaxis, nose plugs, were pretty nasty, and the feeling was, I don't want to put this in, it's uncomfortable and painful to insert. So I called Samira. She was a sister who had nursed him often, and I said, look, he isn't well, he's alone. If you can, please come and see him. She stood at the door of the doctor's room, and the tears were streaming down. And all I could say to her, Samira, I know it's hard. It is very hard to see him like this. And she shared. He used to come up to clinic while he waited for his bloods. He wanted to meet her family. Her husband met him, but he didn't get to meet her kids. What do we do now? We needed to think seriously of stopping all transfusions, as he was now in the terminal phase of dying. Managing his pain was oral morphine, but with the ongoing bleeding, the gastric irritation, the nausea, this was changed to IV, ideally. His pain wasn't controlled, and the dose needed to be adjusted. He was anxious, as anyone would be. We had commenced oral Valium, but as the bleeding worsened, he was more agitated and more tachypneic, and I wanted to start a dormicum infusion. And the other question is, where should he be? Home or hospice? Should we refer to base hospital? But then he would be in a completely foreign environment. And then I come in and I see the mum, and I ask her how she is doing. And she says, I have nothing. There is no one. I can't do this. Phone call comes through, I understand the Zulu. He's bleeding so much, he isn't right. He's having diarrhea. I'm speaking to the doctor. So I prescribed the midazolam and morphine infusion. 4 hours later, Sister D is insistent. He must be transferred to high care. And she refused adamantly to start the infusions. It is my culture. In my culture, we do not speak about death. So he's dying. He's suffering. We owe it to him to control his pain. He's anxious from the bleeding. Her responses were fast, and they shocked me even after 16 years. I don't want a corpse in the ward because of the infusions. Why wasn't this done during the day? I must come and mix the infusions. If he dies, this will be because of the infusions and because of me. And I'm raising this because this is what we are dealing with. These are some of the barriers to providing good palliative care. 6 weeks after his death, she was still insistent. You killed him with the infusions. The doses were too high. You can't give both together. So these were difficult conversations. And I think when one is ill, as Pakamani was, and sitting in the hospital, we have no idea what was going through his mind. He did form a close bond with the registrar and said to her he knows that he's going to die, asked her to read the Bible with him. And at the time of his death, Tabila actually dreamt. She dreamt of him and a message from him to his mom. So doctors' views on palliative care could be anything from we don't do a good enough job about educating families, we need a better palliative care surgeon. As surgeons, we can't fill the role adequately, though I feel we should stay involved. It's hard for me to not seem like I'm giving up or backing out on someone if things don't go well. And there are many, many different perceptions of palliative care. Patient responses, and these are from the Al-Bala course in palliative care, and just looking at some of the sort of religious responses to why certain things can't be done. So a healthy 40-year-old on a GP visit was advised to fill out an advance directive. It's like, I'm not filling that out, only God knows when we die. A 55-year-old with an advanced osteosarcoma says, thank you, no more pain medication. I do not want pain relief. I want Allah to forgive my sins by experiencing the pain. A 92-year-old with advanced dementia, the nurse requested an additional dose of morphine for comfort care, and the doctor's response is, euthanasia is against my religion. I do not feel comfortable increasing the morphine dose. So, what palliative care is based on is an understanding of total pain. And pain not being just physical, but importantly having a significant psychological component, a social component, as well as importantly a spiritual component. And I think these are the things that we don't necessarily delve into, but we do need to be very, very conscious of them. What we experience when we are ill includes fear, loss of control, and a lack of support at times. So if you look at future planning, for example, for a patient with advanced heart disease, over a year, at the risk of dying in 6 to 12 months, but may live for a few years, and that progresses. There are changes, then you can see a more rapid deterioration, and then there's your last days. There's deterioration, which is weekly or daily, with the last 48 hours being the active phase of dying. So this is where we stand, and I've shared the story with you. There are many barriers to palliative care. Those barriers include ourselves, it includes our community's perception of what palliative care is, it includes the structures within which we work. So all of these things need to be broken down. We definitely in palliative care come across many challenging areas, and the HPCSA has recently released their updated booklet on guidelines for the withholding and withdrawing of care. There should also be more discussion on advanced directives, okay, as a community. But this doesn't always happen. And why does it not happen? Because we are at a very difficult intersection. If we think the spaghetti junction, I don't know what the Joburg equivalent is, but that's pretty much what we kind of deal with. On the one hand, we have morals, we have ethics. On the other, we have South African law. Then we have our professional oaths. We have our religious principles. We have fiqh. How do we bring this all together to manage a patient appropriately? And this is what we would like. When that patient and that family is there, we would like for things to be calm. We would like for there to be sufficient knowledge. And ultimately, we would like for there to be agreement, because agreement in itself is powerful. This is an important kind of structure that we use for palliative care planning. It's called the Pepsi-Cola structure, because we needed to keep everybody happy. But it looks at various domains. The physical domain, looking at symptom control, medication, complementary therapies, the emotional domain, understanding expectations, the personal, addressing spiritual needs, social support, information, communication, control. And I think in our communities, control is actually very, very challenging at times. In an effort to protect, we sometimes don't want to disclose. And that's not actually right. So we need to think again, why would we not want to be honest with somebody who is dying? What are we afraid of? So I think there are some unmet needs within our community, okay, and within our practice of medicine in South Africa. And the first appeal is that we need to actually incorporate palliative care at all levels of care, from community level to specialist level. I am very, very clear that there needs to be a change to actually have more structured MDTs within all sectors. I think pediatrics is quite outstanding because we are probably the MDT leaders. But I'm not sure that this extends to both the adult domains and outside of the state sector. Just looking as a Muslim female, and I think about spiritual care, and I think about when somebody is troubled, what happens to them? So as a male, you have the sense of community in a mosque, right? You have an imam that you can approach. It is different. As a woman, I'm sorry, but we don't have the same. We just do not. And this might be very controversial, but there are few imams who are open to sitting and speaking. And who do I ask my questions to? I am blessed. I live in Westville. I have Sufi Mosque just up the road, and I have a good relationship with Hafiz Fazel. But that is unique. I can speak to him. He will make time for me. That is not the majority of us. So where is our sense of community? And who actually is going to answer the deeper questions I have when I am experiencing my spiritual crisis because of the diagnosis I am facing? That is a very, very important need that is unfilled, and we need to look at what we need to do, where the education comes from, where the structures are created, and that space needs to be created. I think within hospitals, it's important, and we have some of this already, in terms of sensitivity and awareness around palliative and terminal care for Muslim patients. And then there's also a call for us to discuss or have wider platforms for ethics and Islamic perspectives. I've got some resources. This will be made available in the pack. There's lots of training available online, pretty good in terms of getting your ethics points as well. And just to remember, the task is not done. The journey is not complete. We can and we must do more. We cannot change the outcome. We know that Allah decides. But we can affect and we must affect how this journey is done for our patients. Thanks.
Jazakallah khair. Thanks, Yasmin. That was a fantastic talk. I think some people are wiping tears out of their eyes here now. We know that from an Islamic perspective, all our care is palliative. Allah subhanahu wa ta'ala is the ultimate healer. All cure and treatment only works with his permission. You know, I was joking about following Bilal behind, but Bilal gave me a fantastic gift a couple of years ago. He gave me a frame, and on it is the Quranic ayat from Surah Shu'ara, وَإِذَا مَرِضْتُ فَهُوَ يَشْفِينِ, which is that from Allah comes the cure. It is Allah who cures you. It is a reminder for us. In fact, I think every single one of us should have that in our rooms. It should be on your computer, your screensaver, so that you understand what your goal is as a Muslim health professional in terms of giving comfort, and that when you give a treatment, it's in the hope of cure, not the guarantee of cure. The cure comes from Allah subhanahu wa ta'ala. And then, I mean, there was I can't remember who said it, but as doctors, we try to cure sometimes, we treat often, but we care always, you know? We try and relieve suffering always. So just, we're into the lunchtime now, but I'm going to allow a few times for questions. We're going to have a men's salah at about 20 past. So I think maybe we give 1 or 2 minutes for questions. And then, everybody's salah actually at about 20 past. So maybe any questions? Any pressing questions? Anybody need some care, some comfort? You do hugs, Yasmin, but only for the ladies. The men, you can find someone to hug. If you need some palliation, I'm available for all the men. Alhamdulillah. Any questions? Yeah, the guys' stomachs are talking, eh? Make the right choices at lunch, guys. Just before you leave, I'd just like to thank our speakers once more. And we have gifts for each of our speakers. I should have given it to you earlier, but I was hoping you wouldn't leave. So please, can you come up, Bilal, Ashraf, Salim, Yasmin, and Nasreen, just to receive your gifts on behalf of the organization and to thank you so much for your participation. I think we've all learned so much on this session, and Jazakallah khair for all of you who attended as well.